Hey everybody, hope y'all are doing well. First things first, yesterday was Lindsey and Keyshore's birthday. So cheers to them. Yeah, so
thanks, Brady.
if I'm mildly hungover, y'all could blame them for that.
Happy birthday.
Thank you.
Yeah.
Mildly.
So anyway, the agenda today, if you did not come last week, we covered all of the gross anatomy head to toe. We did get a little hammered, not hammered. It was fun. But what was I saying? I'm a lightweight. But yeah, so the review from last week, we did gross anatomy. It is on the page, the YouTube page. So y'all could watch that. Today we'll cover all the cartilage and bone stuff and all the genetic stuff from the last week. It shouldn't last as long as the one last week. So we do understand you guys are stressed out. It is difficult to, because you just, the bottom line is you can't learn everything, right? So you have to filter out what's important. So the analogy I like to use is that your brain is an iceberg and the facts that you learn are penguins. So by the time the test comes, your iceberg is full of penguins or information. So every new thing you learn, a penguin gets put on the iceberg and another penguin or fact falls off the other side, right?
They're high yield penguins.
The point is focus on the high yield penguins, all right? You can't learn everything. Learn the stuff that's important, meaning learn the clinical applications, stuff like that. Nobody's gonna ask you to draw the brachial plexus. So, you know, clinical, stay clinical, keep it clinical. All right.
I feel like we need our penguin gif.
We need our penguin. Yeah, if y'all see the running joke on our pages, that's the joke. Penguins get murdered and stuff because everybody forgets everything. All right. What else? Let's see. All right, just a few things. So if y'all been to the reviews, y'all know this already. On the Scrubs page, if you go to the About section, the Term 1 channel that you guys, all of the videos are unpublished, right? So you can't, if you access the channel, they won't show up. You need to bookmark this. If you bookmark that, it'll bring you to the playlist. All the Term 1 videos are here that we've done since Lindsey and I started this thing. So all your stuff will be there. Just a side note, if you are going down to the island and you haven't seen the Back to the Island Q&A that Lindsey and I did, Keyshoe was there too, I believe, yeah. If you haven't watched that, you might want to watch that. Got some information on going to the island. We look forward to seeing you guys down there. Lastly, this is not affiliated with school or IEA, but you should join the follow IEA on Instagram. Once the next term starts, we're going to start doing the facts of the day again for each term. Also, all of our tutoring, the honor students all do tutoring. So all the information will be here. It'll be on social media. For those of you fortunate enough to get above a 90, you'll be able to join IEA, the Honor Society, and you'll be able to offer tutoring. There's a lot of good benefits that go along with that. So follow IEA on Instagram and keep an eye out when the next term starts on social media, on your Facebook page, class page, and we'll send out the applications for that. All right, Lindsey, you got anything to add before we get going?
Nope, but if y'all want to go follow the SGA IEA Instagram too, go for it. Yes.
Lindsey is now the School of Medicine president for SGA. All right, so let's get going. And as always, this is very informal. So if you guys have any questions, just stop me and we'll go through it. All right, I'm on Scrubs. You'll find all my information there. Lindsey runs Dog Mom DES. Go check out the additional resources, just a bunch of stuff in the folder, charts, tables, graphs, questions, anything you might find helpful. All right, make sure you're doing the grades questions. The best linear correlate to how well you do on these type of exams is how many questions you do. The boards have shown statistical evidence. The best scores come from the people that do the most questions. That doesn't mean slack off on the other stuff. It just means at some point you have to go from passive learning to active learning. like soon, because, you know, obviously the closer you get to the test, the more questions you want to be doing. There is an art to answering these questions. You know, it's not just do you know the information, but how well you can understand the way the question is set up. So do the Gray's questions, do the Sakai questions for the stuff we're going to do now, and you should be good to go. So let's start out with this. Yeah, go ahead and private message any of us with these answers. All right, so let's take a look. So a couple of buzzwords, y'all are going to get into this in pathology later on. They're just kind of introducing you to this stuff. Key things here, no scab, meaning you already went through the process of injuring yourself, the inflammatory mediators got there. You formed a scab, the scab healed to a degree, and the scab fell off, right? So we're deep into the process or further along into the process. It's actually the maturation phase. So you can see here, as soon as you get some sort of injury, you get vasoconstriction to stop the blood flow, and then you get some of these mediators, these inflammatory mediators that go there, and then you also then as the blood stops and you kind of clear the infections or put it at bay, you can the scab will form over that, and then after the proliferative phase will be when everything kind of grows back together and holds strong. And then the maturation phase is the phase we're talking about. That's the point at which there's no scab left. And this scar is kind of they refer to it as a hypertrophic scar, right? It just kind of pinches together, right? As everyone's been injured and knows what I'm talking about. It kind of has that pinkish appearance to it, right? So those are the classic hypertrophic scars. Okay, so even though the formation of cartilage and bone seems very similar in their orientation, they are completely separate. Some of the words kind of carry over, and we'll talk about that. But the formation of collagen and cartilage is separate. But in the process of bone formation, you actually form cartilage first, okay? So keep them separate, but they do kind of go hand in hand, if that makes sense. So we'll kind of go through these. Anytime you see these grouping patterns, these what they quote, they say isogenous groups, you want to think about cartilage, okay? This is kind of how these cells form. You want to keep in mind the different areas. They could easily put some sort of histology slide on there. So capsular matrix is going to be within one of the cells, one of the collagen cells or the cartilage cells, or one of the little groupings here. The territorial matrix is going to be right around it, right around the little grouping or in between the grouping. And the interterritorial space is going to be between separate isogenous groups, okay? So I seem to remember, even though it seems like we were doing this so long ago, that they did ask sort of questions similar to that. Now, there are 3 different types of cartilage, and being able to identify the differences here is going to be important for the test. Remember that cartilage is type 2 collagen, right? So the way to remember that is cartilage. 2 is type 2 cartilage, okay? So that's what we're talking about here. Hyaline cartilage, you could see, they talk about it as having this glassy appearance to it. So you could see that here. Elastic cartilage, this is a special stain they use. It's very similar to hyaline cartilage, except it has these elastin fibers here. And for a question coming up, I'll give you all a hint. You don't necessarily need to use this stain here, okay? And I put the question coming up dealing with that for that exact reason. And then fibrocartilage is more of a tougher type of cartilage, like fibrotic, you know, it's not fibrotic, but fibrous tissue. So it lays down in these grouping patterns. You see these linear groups right here. So it lays down flat. So you want to be able to differentiate these histologically and in their different patterns of growth. So hyaline cartilage is the main one we're going to talk about. Whoops. And you could see that here, you see these little isogenous groups and this glassed over sort of appearance here. What I want you to focus on is these different things. The growth, there is appositional and interstitial growth, which we're going to get into. It does not degenerate and it will calcify. Okay, so there are differences between the different types of cartilage. One of the important things is hyaluronic acid is part of this. These gags are commonly considered that they hold a lot of water. So by doing that, they act as an absorptive or a cushioning effect. So keep that in mind. So definitely no growth, degeneration, calcification, because that's going to help you differentiate it on the test. Now, you want to differentiate this from bone, but appositional growth always grows from the perichondrium. All right, chondrium meeting cartilage. So perichondrium is the outside of the cartilage. You have to have a perichondrium to have appositional growth. Okay. That's easy points on the test. If there's no perichondrium, which we'll look at some of the areas that don't have it, you can't have appositional growth. Now, interstitial, kind of, which means inside, grows from the inside, and we'll take a look at that too. Now, there are some differences in bone, and when we get to that, we'll talk about it. So, the joints, the articular cartilage, like at the points where joints come together, there is no perichondrium. And that makes sense because if a joint, think about your hip bone, right, into the pelvis. If the femur is in the hip bone like that, you really don't want that articular cartilage growing anymore because it fits tightly in there. So the articular cartilage is type 2 collagen, and it is hyaline cartilage, but it doesn't have a perichondrium. Therefore, you won't get appositional growth there. Important point. Okay. Now we look at elastic cartilage. So some of the difference here, do y'all remember which ones? There was like a way of remembering what is elastic cartilage. It was like pinna, it was like the P's. Do you remember, Kishore? The pinna, what was it? Do y'all know? E's? What?
Epiglottis, ear.
Epiglottis. What else? There was third one, right? Epiglottis.
Eustachian tube.
Eustachian tube, that's it. Good job. Yeah, right. So if you think about that, right, exactly. So, and if you think about that, those areas aren't going to calcify, okay? So the ear, your ear is not going to get hard. It's not going to calcify. But that does differentiate it from hyaline cartilage. So this is elastic tissue. Recently, they started using, there's different types of elastic tissue with people's names and stuff. So you may want to learn those. I think I have a question of it, about it coming up. But this is a classic elastic stain. You can see these little elastic fibers kind of intermixed in there. Okay, and then fibrocartilage. And you could see if you trace the little cells here, you could see they're kind of laid down in rows, okay? So the growth, there is no perichondrium involved. You're only going to get interstitial growth. So it's only from the inside. Okay. And so definitely make sure you know this. This is, I guess this is a Mallory trichrome stain. Looks like it. All right. Try this one. All right, so I put this in here for a reason. It is from Lippincott, so technically it's fair game, but this is actually elastic cartilage. The reason I put it in here is because, here it is. The classic image we see is this elastic stain, but I don't want y'all to get tripped up and just think automatically this is hyaline. Ideally, they will use this stain because you can appreciate the elastic fibers better, but identify the isogenous groups. They do have elastic fibers in there. But yeah, so again, make sure you can differentiate these. You don't really see, if you really had to determine it, you really don't see this glassed over appearance, and the cells are kind of more bunched up in this picture. Would be a tough question, but I just wanted to show y'all that. All right, small little differentiations here. Try this question. Cool, right. So remember, what are we talking about with appositional growth? We're talking about perichondrium. Now, here's the thing I want you to keep in mind. Oh, remember, so when we talk about, let's get into the blasts and clasts, right? So chondroblast, chondro meaning cartilage, blast, I want you, when you see the word blast build, okay, BNB, blast build. So chondroblast, these chondroblasts are gonna build cartilage. Clasts are gonna eat it away, okay? So the chondroblasts are gonna lay down cartilage. And when we talk about the bone, the osteoclasts are what we're going to talk about in that regard. But just remember for right now, just remember the blast build, okay? And anytime we're talking about appositional growth, we're talking about the perichondrium. Now, the difference here is that when we talk about interstitial growth, we're not using chondroblasts. We're actually making mature chondrocytes. You're in the inner part of the cartilage, you're laying down fully formed chondrocytes, okay? So that's how you're building. So remember, keep the blast on the outside and you're laying down fully formed chondrocytes in for the interstitial growth. Yeah, so right, interstitial growth. Okay, and this, just showing this again, right, so the appositional versus interstitial, that's how we're gonna do it. Y'all don't really need to worry about this too much. Obviously, growth hormone, anytime you talk about thyroxine is basically your thyroid, your T hormones, your thyroid hormones, they're involved in metabolism. Y'all will get into that later. So obviously building bone, testosterone obviously helps to build any sort of glucocorticoid will kind of stunt your growth and stuff like that, even estradiol. Y'all will get into that later. I don't think that's terribly important right now. All right, so let's look at now we're gonna switch over to the bone. But even though it's a different process, watch how some of the words carry over. Now, instead of using chondroblast, we're gonna use osteoblast, osteo meaning bone, blast meaning build. But you could see here, the perichondrium is gonna lay on the outside of this bone. And this is a very important point because when you talk about appositional growth, you're talking about width, okay? The bone is getting wider. Okay, and that makes sense because if these osteoblasts are laying here on this periosteum, right? So you need an appositional growth, periosteum now, and then these osteoblasts. By laying down these osteoblasts, they can form osteocytes and the bones get wider. We're also going to talk about endochondrial growth, and that's how the bones get longer, right? And that's from the growth plate, which tends to close around 18, right? And that's when you stop growing, around that age, right? So again, remember, keep the blast on the outside, and then these osteocytes are going to be more towards the fully formed bone. Okay, somebody help me out here. What are we looking at? This is fair game for the test. If we said this is some forming of the bone, what do y'all think one is?
Blast.
Yeah, right? Like, let me go back. You see this? Right here, look how it's laying on the outside of the bone, right? So look here, you see the bone forming? Yeah, so we would say this periosteal layer is right around there. So it is making the bone wider, thicker, right? Okay, now what about two? What are these big multinucleated cells? Yeah, osteoclasts, right? Gonna eat the bone away. They are controlled by PTH, parathyroid hormone. And parathyroid's hormone is going to, y'all did cover that, right? PTH, yeah, y'all did vitamin D.
Yes.
Yeah, to a degree. We'll talk about it in a little bit. Yeah, so with PTH, parathyroid hormone is released. You're going to increase your blood calcium, okay? But we'll get there when we get there. All right, so yeah, these multinucleated big cells are the class. They're going to eat away at the bone. It is kind of a last resort. Ideally, your vitamin D levels are good. You'll absorb the calcium. All is well there. If for some reason you have a calcium deficiency or vitamin D deficiency, the last resort is PTH to be elevated. You're eating calcium off the bone, but again, this is a last resort thing. Ideally you would just get it from your diet and modulate it through the kidneys. All right, so just I remember thinking confused. I'm like, why do you want to eat the calcium off the bone? It's like, well, this is a last resort kind of thing if you're at a deficit, a severe deficit. What about three? What are we looking at three? Yeah, osteocytes, right? You could see them in this matrix, the lacunae, right? They're sitting in the matrix. Yeah, so they're the fully formed cells. Cool. All right, just a summary. Y'all could read this on your own if you like. Same thing here. We're going to talk about the canals. Now, just for completeness sake, there is this intramembranous bone formation. This is confined to the flat bones. They use these a lot for bone taps, for bone marrow biopsy, or bone marrow taps, bone marrow biopsies, like in the hip and stuff. So you could do these, but if you, anytime you're talking about the intramembranous, you're talking about flat bones of the skull, the pelvis, stuff like that. When we talk about the long bones, we're going to be talking about this endochondral bone formation. This is a very important slide. You will get a question on this. They like this at clavicle 2 as well. Yeah. So you're going to see this picture a lot, right? So we're going to walk through it a little bit coming up, right? So remember that the epiphysis is here, diaphysis is down here. So you're going to start here. Remember I said that the bone formation is going to start out as chondrocytes, all right? So you actually have calcified cartilage, you have reserved cartilage. They talk about this zone of proliferation as a stack of coins appearance. Now, if there's anything you could get confused, it would be the zone of proliferation versus zone of hypertrophy. My advice would be to find both of them, okay? If they're asking for one or the other, just find the proliferation, you're going to get an increased number, and then find the zone of hypertrophy, those cells will get bigger. You have to increase the number before you increase the size, okay? So this stack of coin appearance is going to be formed first. Now, think about it like this. If you have this cartilage here on the end of the bone, as the cartilage forms into actual bone, it's going to lay down on the shaft of the bone, right, on the diaphysis. And this is going to be your growth plate. So we're going to look at, I think I have some more questions coming up. Or some question that y'all can look at here. Now they do this. I forget what the stain is called. Do you remember what this is? This stain. What is this called?
Indian or Indian ink?
Indian ink. Yeah, that's it.
Indian
right?
ink.
Yeah. Okay. So yeah, we'll just look at the cartoon here. The Haversian canal is going to be coming through this osteon, and it's going to bring blood flow through. The perpendicular canal that goes across is Volkmann's canal. Now, they could ask you about the osteon. Those are going to be those concentric layers that form around the vessel. I think about it as like the rings around a tree, right? The older the tree gets, the more rings it gets. It kind of looks like that. And you could see these interstitial lamellae are basically old osteons that are remnants of it, right? When the new osteons come up, they kind of take over the area. And then there's these outer layers, the circumferential lamellae, the inner and outer one. But these are going to be fair game as well. So find the circles, find the osteons. 3 is going to be your Haversian canal. That's going to be the blood flow that comes up. Let's see, Volkmann canal. Oh, you can see it here, right? It runs perpendicular to this. You can see that. And then the osteon is going to be this whole circle, like the concentric rings. And I think that's it. What is 4? Yeah, the interstitial lamellae, right? Those are the old osteons that used to be there. And then if we zoom in a little bit, the interstitial lamellae over here, you can see the whole osteon, the Haversian canal is in the middle. 2 is going to be the lacunae. The lacunae is where the fully formed osteocytes live. Okay, so how it works is that 3, where's 3? Oh, you could kind of see it here, but you could see these canaliculi are little pathways for nutrients and whatnot to get to the osteocytes and for communication. So you could see this, but fair game, the osteocytes are in the lacunae, they communicate through the canaliculi, all right? So you got to get blood flow nutrients to keep everything alive. All right, try this one. Yeah, good. So, right. So when we think about that appositional growth on the periosteum, and you think about those osteoblasts laying down there, this differentiation, these osteoblasts are going to form from the mesenchyme to the osteoblast to form these osteocytes for this appositional growth. So anytime you see stimulation of differentiation, you're trying to lay down more bone, right? Versus osteoclast when you're trying to resorb it and get the calcium back into the blood. Yeah, right, and we saw that in the picture. Okay, y'all didn't, well, this is kind of going back too, but this is a good question. Go ahead and try this one. All right, so it may not be directly evident, but this is a good thing to know in the future. Osteoarthritis is going to be classic. You're going to see this, these bony, what do they call them? These, they're bony enlargements, but they're like osteophytes, I believe is what they're called. And they form, these nodules form at the DIP joints. It's very classic for osteoarthritis, okay? So just keep that in mind going forward. Why is this common? Why is osteoarthritis common in postmenopausal women? Low estrogen, exactly. Estrogen has the effect of inhibiting osteoclasts, all right? So for premenopausal women, the estrogen will block the osteoclasts so you don't resorb bone. For postmenopausal women, the osteoclasts can work without inhibition because there's not a lot of estrogen around, okay? So they're gonna eat away. That's why elderly women tend to get osteoarthritis. Okay, keep that in mind. It's actually through the osteoblast. There's the osteoblast inhibiting factor. It may be out of the scope of this curriculum, but just in case they ask, but it does inhibit the osteoclasts. Yeah. And you could see that, well, yeah, go ahead and answer the question. And this is why a lot of times that postmenopausal women will actually stay on birth control or get some sort of exogenous estrogen to prevent not only the symptoms of menopause, but the degeneration of the bone. All right, so postmenopausal women will have increased osteoclast activity. Again, that is because of the decrease in estrogen, right? Okay, so let's look at this. I would bet, whoops, I would bet that this would be on your exam. So make sure you could identify these. Yeah, right. So be careful because we're talking about area 3. Now, what is area 2? That is going to be your zone of proliferation. That's where you're going to get this stack of coins. So this is the reserve cartilage over here. You're going to get the proliferation, right? Increased cells, the stack of coin. And here you can appreciate it's kind of difficult, but you can see that some of these cells are getting larger. So that's the zone of hypertrophy. Okay. So, and yeah, you could see zone 2 proliferation, that's our stack of coins. So the idea here is if you find both, you could kind of differentiate it. But if you were to mix these up, mix this question up, that would be where it is between hypertrophy and proliferation. So yeah, find the stack of coins when they get bigger. That's hypertrophy. Remember, you're starting at the end of the bone and with cartilage, and once you get to the shaft, that's when you're laying down mature bone. Cool, try this one. Yeah, primarily area 2, the zone of proliferation is going to be the larger of the zones. So your growth spurts would be pretty much in that area. Right. So like I was saying, that proliferation zone is going to be where most of the growth goes. So if we go back and look at it, you could see that it's the larger of the zones. You're increasing the number of cells. So that would kind of make sense, right? And that's what, obviously, if you're increasing the number of cells, there's mitotic division going on. All right, and then once again, we're looking at it going from up top to down low. You could see reserve cartilage, proliferation to hypertrophy. It's easier to see here that these cells are getting larger, but it may not be so obvious on the exam. But I'm going through this a couple times, so definitely know it, right? All right, try this one. Yeah, this one's a little tough, right? So it's basically asking if you can define what the soft callus is, right? So the soft callus is going to be cartilage and dense connective tissue. That's what we're going to be forming here. So you could see initially when you have a fracture, you want to form a blood clot, right? You want to stop the bleeding, and then you could form a soft callus, right? And then from a soft callus, I think there's another slide, you could form a harder callus with spongy bone. And then once the spongy bone is remodeled, you get compact bone, right? So spongy is going to have like a sponge, going to have holes in it, and it's going to form fully compact bone, right? So this is the area that we're talking about. This soft callus, dense connective tissue is what you're thinking of, and obviously fibrocartilage is involved. All right, again, y'all will do this a lot more in pathology. I just wanted to mention it to you guys. And then once we actually have this fully replacement of the bone, it's going to be endochondrial, right, from the inside, growing outward. All right, you need to know vitamin D inside and out just forever, so go with this one. Yeah, they really like this vitamin D pathway. So this is actually common. This is a pertinent clinical correlate, right? So the point being, chronic renal failure in the kidneys is where you actually have this one hydroxylase. One hydroxylase will convert 25 vitamin D to 125 vitamin D. 125 vitamin D is the active form. So if we look at the pathway, this is the metabolism pathway, as I said, 25. It is turned into 25 in the liver from cholecalciferol to 25. By 25 hydroxylase, technically, if you have liver failure, you can have issues there, but they really like testing on the kidney failure, the renal failure, just because it's that conversion from 25 to the active form, right? So if you can't form the active form, the enzyme you need, it's a problem. And the enzyme you need to know, 1-hydroxylase there. So let's see. All right, so we'll go through the process. Vitamin D and PTH work together, right? The whole goal is to keep your calcium levels up. Now, there are a few little differences. Vitamin D is primarily going to work in the intestines, in the gut. The vitamin D is going to be it's going to be transcribed. It works similarly to a steroid hormone. It goes into the nucleus. It is going to basically pull all of the excess calcium from the lumen, from the meal you eat, and bring it back in. It's also going to absorb phosphate too. So calcium and phosphate in regards to vitamin D are going to go together. Okay. Now, in regards to PTH will primarily work. Ideally, it'll work in the kidney. Now, the difference here is that it will tell you to reabsorb calcium, but it'll also tell you to get rid of or urinate out the phosphate. You don't want calcium and phosphate technically together a lot in the kidneys because you could form kidney stones, right? So big difference y'all need to know right now, and y'all will get into it in much more detail later. But the big difference is that vitamin D is going to absorb calcium and phosphate from the gut primarily. PTH in the kidney is going to keep calcium, get rid of the phosphate. Okay, so when you talk about some of these disorders that they have, you could see elevations or differentials there with hyperparathyroidism and stuff. So keep that in mind. And like I said earlier, ideally the PTH doesn't want to act on the bone, right? It will if it has to, but ideally you could handle it in your gut. But if there's for some reason there's a big deficit, it can go eat up on the bone and because obviously you need to have your calcium levels adequate in the blood. So if it has to pull it from the bone, it will, but that's not an ideal circumstance. All right, good. Right, and you can get like tertiary hyperparathyroidism with vitamin D deficiency. Vitamin D deficiency, then you get decreased calcium, and then you get increased parathyroid hormone. So it's another thing when y'all get to endocrine next term. Y'all will talk about that in much more detail. All right, genetics, and some of these genetics diseases come back again and again because they like to be tested. Whether we'll see them clinically, it's not exactly important. It seems like every other person has Marfan syndrome, but you may never come across it in clinical practice, but it's just a good way of testing some of these genetic principles. So go ahead and try this one. Get out of here. I don't know, have y'all covered pheochromocytoma? Have y'all? It's a running joke.
Yes.
Like everybody that has like elevated heart rate has pheochromocytoma. It's like, it's fairly rare, right? Like but yeah. All right, what are we doing? Okay. Fibroblast growth factor, you need to know these genes. Again, one of those things, the sooner you learn them, the better off you'd be. So what are we talking about? It's trident hands, and I like this question because it's not exactly intuitive when you talk about it. So what disease are we talking about here? Growth factor.
Achondroplasia.
Achondroplasia, right? I try to remember growth, fibroblast growth factor. Talking about achondroplasia. Now, I think we talked about previously, there are 2 gain of function mutations that you need to be aware of. Huntington's disease, you gain the function of this, this flailing movement. Y'all know about Huntington's with the anticipation, right? Those trinucleotide repeats. So, and the other one, the other gain of function mutation you need to understand is achondroplasia. And you may say, well, what is the gain of function? Technically, the gain of function is the gain of the ability to close the plates. It's not a good thing, but it technically is classified as a gain of function. Now, by closing those growth plates, by closing the epiphyseal plates, obviously that'll stunt the growth. Now, let's do this. Well, not exactly, but if you didn't necessarily know trident hands, you want to use the test to your advantage. This is one of those art of taking these sorts of tests. Sometimes it's easier to rule out 4 answers than it is to rule in the correct answer. People that write tests are good at writing tests. The doctors that write the board exams, that's their sole job, right? So they know what they're doing, but the more questions you do, the better off you'll be. So pigeon chest is classified as Marfan syndrome. Brittle bones, you know, OI deals with brittle bones. Cardiac abnormalities is kind of vague. It's very common in Down syndromes. You get VSDs. We'll talk about that when we get to cardio. DeGeorge, y'all know catch-22. The C in catch is for cardiac abnormalities. And then MR is many causes. So point being, you need to know these genes. You could kind of get it from the other stuff, but if you know the genes, you definitely know it. All right, we kind of just talked about this. Huntington's disease, achondroplasia, you need to know those as gain of function mutations. All right, try this one. Pigeon chest can be rickets as well, yeah. But that's more of, rickets is more of a nutritional deficiency. So you wouldn't, you know, when we're talking about these genetic deficiencies, you know, it does happen in Marfan's too, but it has to do with, you know, the fibrillin gene, the cartilage lacks cartilage. But yeah, you could see pigeon chest and rickets, and they also have the bow leg, yeah. All right, so this is actually fairly common. What they'll say is a child comes into the ER and for a fracture, and when you do the x-ray, it looks like there are multiple fractures that are healing at different times. So you call child services, right? You're like, what's going on? Why are there so many fractures at different times? But in regards to these questions, a lot of times this has to do with osteogenesis imperfecta. Now, again, if you knew this gene, you would get it right away. But even if you did it, you could kind of get it from the questions, right? So some of the differences, blue sclera is just a straight giveaway. You know, that's osteogenesis imperfecta. Sometimes they get hearing loss. They do get short stature. But that's the main ones. That blue sclera is definitely a giveaway. And you're looking at fractures that are healing at different times. Okay, as for these, y'all will get into the yellow sclera later. Has to do with bilirubin. A lot of liver problems, liver diseases can cause that. Again, in regards to genetic deficiencies, pigeon chest is Marfan's, and ruptured aorta is Marfan's too. This is why people with Marfan's are not allowed to play sports. I don't know, I probably told y'all this already because I think this is a crazy story. There's a guy that he was like 20, played for Baylor. He was getting drafted into the NBA, and he had historically in his past, he had subluxation of the limbs. You guys, we all could look at him and be like, that dude's got Marfan's. Like, his fingers were long, he's 7 feet tall. Throughout his entire youth career, nobody diagnosed him with Marfan's. He gets to the league, he's about to make millions of dollars, and they said, you have Marfan's, so we're not going to draft you. And so he lost millions of dollars. But the point of the story is that the clinical complication of Marfan's is this ruptured aorta. You get a tearing of the media in the aorta, the middle layer, and it could lead to sudden death. Okay. All right, try this one. He's playing in a different league. I did not know that. That's wild. Huh. All right, so this is a little bit more complex. We're kind of diving into the different variations of osteogenesis imperfecta. Now, the point mutation is going to be a dominant negative mutation. So we'll stop and we'll talk about the differences between dominant. So basically, you were going to go between, it's between A and B, right? One's haploinsufficiency, one's dominant negative. So dominant negative means that you have some normal protein, for instance, and some abnormal protein. So the dominant negative one is going to counteract the positive one. So in regards to the bone formation, they're going to be very brittle because you have some normal, but a lot of abnormal, right? So it's going to be very brittle. Haploinsufficiency just means you have a decrease, whereas you're supposed to make 100% of this protein, you make 75% of that protein. It's all normal protein that you're making, you just have decreased amounts of it. So it's an insufficient amount. Whereas dominant negative is you're making normal and you're making abnormal, and this negative effect of it is going to counteract the positive. So it's important to know that, because in regards to the different ones, different correlates. So a nonsense, remember sense means it's going to cut the DNA strand. It's going to have insert a stop codon there. So that's going to be OI type 1, whereas missense is going to be switch that amino acid around. And that's type 2, and that's a dominant negative. Fair game, they could ask you this. So this is from your notes or from our old notes, whereas type 1 OI is going to show the blue sclera, type 2 is very severe. And so when we think about this in regards, remember OI is a structural protein problem. So why is type 2 worse than type 1? Well, this dominant, in regards to a structural protein, this dominant negative effect is worse than a haploinsufficiency, meaning it's better to have less of a proper protein, right? Haploinsufficiency, than have half normal protein and half abnormal, okay? So even though an insufficient amount, at least it's all normal, right? It's still going to be brittle, but it's not that bad. It's not as bad as having these completely messed up, this messed up portion of them. So that's in regards to that. But keep those separate. And you can kind of see that here. Let's see, this missense mutation is putting in these abnormal proteins. So this is what this slide was kind of getting at here, the severe thing. So the idea is that you're getting 100% of a protein, but half of them are messed up. So the bone's just going to fracture. Whereas with the haploinsufficiency, opposed to getting 100%, you're getting 80%, but at least all 80% is normal. You just have a decreased amount of it. You can see that, yeah, this haploinsufficiency. So you get normal, they're normal, they're just less of it. All right, and it comes to this, and so this is why I'm harping on this. You can't just definitively say that, well, in that case, haploinsufficiency is always going to be better than a dominant negative mutation. It is in regards to structural proteins, okay? But when we're talking about enzymes, it is worse to have haploinsufficiency because you're going to get this nonsense in regards to nonsense mutations. Because in regards to the enzyme problems, if you get a nonsense mutation, you're going to mess up the enzymatic process, right? So it's going to be completely messed up. Okay, so this is getting a little more complicated, but this was in the notes, so I just wanted to make sure to go through it. So just read through these and understand that the bottom line is that you can't definitively say haploinsufficiency is better or worse than dominant negative. It just depends on what we're looking at. Is it an enzyme problem or is it a structural protein problem? Because that'll kind of tell you which one's the worst situation. All right, try this one. And what is this? What are the two and which one is this? Does it say in the question? No. Becker's is in frame, this is DMD, right? So if you're thinking about it, frameshift mutations are really bad, right? It changes because you're bumping the amino acid or the codon down one, right? One base pair. So that means that all of the amino acids, the triples, the three codons are going to be different all the way down. So a frameshift mutation is going to be worse than an in-frame mutation, right? An in-frame mutation would just change that one amino acid, like a missense mutation, whereas a frameshift is going to change all the amino acids all the way down. Therefore, Duchenne's, which is frameshift, is much worse than Becker's, which is in-frame. Okay, and they say some books say complete absence, some books say almost complete absence. There's basically no dystrophin there. Okay, the dystrophin protein because of this frameshift mutation. And sadly, these children typically are wheelchair bound by 20. They die by, I'm sorry, wheelchair bound by 12. They usually die by 20. So this is commonly, this is not they have a zero reproductive fitness. The assistant passed along. This is a de novo mutation that happens in these kids. Whereas Becker's is in frame. Some of them do get to reproductive age, but so you have decreased amounts of dystrophin, whereas Duchenne's is a complete absence. So you can see that here, if they stained this, they did a muscle biopsy here and stained it, you can see this bottom is Duchenne's. You don't see any of that dystrophin. Becker's, you see a little bit, and this is normal. So again, frame shift, in frame, normal. All right, if it was like us, this was like a 70-page DLA or something. I don't know if y'all had that too, but I'm sure y'all cover the same material regardless. But we'll talk about some of the diseases that were covered in that. All right, cool. So let's walk through this one. Okay, so these the liver enzymes are in charge of metabolizing drugs, right? They are called CYP450s. That's kind of the umbrella name for all of them. But some of the, so they'll be like CYP3A4 or whatever. But the one we're talking about here in this sense is the specific CYP450 called CYP2D6. Now, what you need to know is some medications, the majority of medications that you take are active when you take them, and then when they hit the liver, they are inactivated. But some medications that you take are inactive, and then the liver is going to metabolize them into the active form. So this guy was given codeine. Codeine is the inactive form of morphine. Let me just draw this out for you guys. So this is codeine. Codeine is changed to morphine, okay? Morphine is the active form, codeine is not. So the idea here is that he metabolized codeine too quickly, right? Now, by metabolizing, like when the pharmaceutical companies have a general understanding of this is how much is going to be metabolized the first time through the bloodstream, through the liver, through the second time. So if you are an ultra rapid metabolizer and you take the inactive form and are metabolizing it to the active form, you're going to metabolize it too quickly, meaning you have too much of the active form in your blood. What are the side effects of morphine, right? The side effects of morphine overdose is respiratory depression. Where does it say that? Difficulty breathing. Okay, so this is an example of you taking something inactive. The liver, this CYP2D6 is going to activate it, or sorry, is going to metabolize it to the active form. Okay, morphine. Right, so that's used for analgesia, for pain, so if you're an ultra rapid metabolizer. Now, the other example that they give you is metoprolol. Okay. Metoprolol is a beta blocker. It's used for blood pressure, for stage fright or stage anxiety. It helps to regulate your heart rate, whatever. Y'all don't need to get into that. Actually, y'all did cover that, I think. Anyway, it's blood pressure medication, but we want to use it here in this regard. So let's just use X as an example. Metoprolol is active when you ingest it. Okay, so let's say you are a poor metabolizer in this case. The pharmaceutical company is going to assume you being a normal metabolizer, you're going to metabolize a certain amount of this metoprolol in a certain period of time. But if you're a poor metabolizer, that means you're going to have too much of the active form. You're not going to metabolize it to the inactive form quick enough, okay? So you can get symptoms of feeling faint or hypotension or orthostatic hypotension, where when you stand up, you feel lightheaded and stuff. Even bradycardia, your heart rate will go down. So you can see the difference here, right? So you need to remember codeine is inactive, changes to morphine. You can see problems with that with ultra rapid metabolizers. And metoprolol, which is already active, is inactivated. So if you're a poor metabolizer, you'll have too much metoprolol. All the drugs go through this process. These are just two examples that they want you to know. What you'll come to find is that there are even medications that will affect these CYP450 enzymes, stuff such as grapefruit juice. People drink alcohol with grapefruit juice because the alcohol stays in your system longer. That's because grapefruit juice will inhibit these CYP450 enzymes. So you'll see that certain medications or certain diseases, you can't take other medications because they will slow down or speed up these. So this is going to be a common thing. You need to understand the differences there. All right, so there's explanations here for you guys. Talk about these. TMPT polymorphism. Okay, so they give, so for diseases like bloodborne cancer, such as leukemia, they can give certain medications, these thiopurine drugs. They help to decrease the amount of purine synthesis. Y'all kind of touched on that in FDM. So if you have this TMPT polymorphism, you're going to get too much of this drug in your system, and it's going to oversuppress, lethally oversuppress the leukemia. So the idea of these thiopurine drugs is you're going to decrease the amount of extra blood that you're making. But if you have this polymorphism, it's too strong. Okay, so that's all you really need to remember. Keep this TMPT polymorphism in line with myelosuppression, like too much myelosuppression. Okay, this ranitidine receptor is an important thing too. So what are the two drugs? Succinylcholine and what's the other one? Halothane, that's it, thank you. Succinylcholine and halothane, they use those for anesthesia. If you have this ranitidine receptor mutation, what ends up happening is when you take halothane or succinylcholine, this ranitidine receptor, there's an influx of calcium that's uncontrolled. So you end up getting these, you end up getting tetany, right? Because the calcium, you'll lock up, and you also get malignant hyperthermia, and that's because of the muscles locking up. So this is a big deal. It's very rare, but it's something they test on. So this ranitidine receptor allows calcium to flow in. So if you have a mutation there, you'll have too much calcium. The patient, will be going under for whatever sort of procedure. You'll give them typically succinylcholine. It's a non-depolarizing. You'll get into that later. Blocker, but so you'll give them that, and all of a sudden, their muscles will lock up, their temperature will go up, and that's a huge problem, right? So keep those. Yes, that reaction is specific to halothane and succinylcholine. Yeah, they'll put that in the stem so you know what they're talking about for sure. Fragile X, that's one of those trinucleotide repeats, along with Huntington's, myotonic dystrophy, and Huntington's, and there was another one too. I can't remember off the top of my head, but yeah, those. Okay, and then this is what we were talking about, these poor metabolizers. So you can go through this on your own. If you're still confused, I'll stay back after. Yeah, ataxia, that one. Frederick's ataxia was the other one, thank you. And we could go through this again if you're still confused, because it is a good point to be made. All right, try this one. More importantly than getting the answer, you could tell me what disease we're talking about. Yeah, so this sudden, jerky, purposeless movements, it's bilateral, which is important. So you're going to get this is Huntington's disease. This is called choreiform movements. This jerky, purposeless movements. They're uncontrollable. Yeah, so this is Huntington's. You would expect this anticipation, right? So if the father got the disease at 50, or the onset of the disease, his child, the guy in question here, will have more of that CAG repeats, right? meaning you can anticipate that he will get the disease sooner. It's a very rare situation where you have a genetic problem that you're born with that you don't actually get until adulthood. I mean, besides some cancers we talk about, but the idea that, I mean, you could think about the idea that, you know, your father got it at 50, this very severe disease, and you're likely going to get it before then. But what you'll find out when you get to neuro, the caudate nucleus is what degenerates, and I think there's a picture of it. Yeah, the caudate nucleus kind of sits like right up in here. Right, so over time, this ventral gets larger and this caudate nucleus degenerates. I don't think it's as important to understand this, to necessarily be able to point this out on some sort of CT, but just knowing that Huntington's disease, the anticipation process, and this these choreiform movements that form. This is super important. Star this slide. These are the 4 trinucleotide repeats. I think you should know everything on this slide. Like, you need to know that Fragile X is before the start codon, right? It's in that 5' untranslated region. That's a good question. Huntington's disease and spinocerebellar ataxia. I don't think they'll ask you about spinocerebellar ataxia, but it does. They both have that CAG repeat. Spinocerebellar ataxia is more of like a problem with balance than it is this jerky, purposeless movement. But yeah, you do get this this ataxic gait, trouble walking, but I doubt they would ask you about that one. If they talk about it, they would talk about one of these 4. So knowing that 5' untranslated, right? 5' is where we start. AUG is our start codon. Fragile X is before that. And just knowing these, what actually is the problem that forms from these actual repeats is going to be important. Friedreich's ataxia is in the region. Definitely knowing the different patterns, X-linked versus autosomal recessive. And what else was there? Oh yeah, that it's in the intron, not the exon, because Huntington's is in the exon. The point of this is like there are all very little differences between these, and they all could be asked about. Okay, gain of function. Remember Huntington's, we talked about that, and then myotonic dystrophy is going to be on the 3' untranslated region. Okay, so definitely know these. Oh yeah, I thought we were done. I guess not. All right, let's do these. Muscle physiology. Great. Yeah, y'all are getting this. So the idea of myasthenia gravis is that they have autoantibodies that attach to these postganglionic receptors, right? So it's a little tricky because your first instinct is saying, well, it has to do with acetylcholine. But in order to have acetylcholine release from here, you have to have sodium, okay? So sodium is the answer, but that's definitely a tricky question. Y'all did good with that one. But remember, this versus Lambert-Eaton syndrome, people with myasthenia gravis, if you ask them to repeatedly move, they get weaker over time. This is why they complain of weakness at the end of the day. They have ptosis, which means their lid gets droopy throughout the day. The difference is with Lambert-Eaton syndrome, y'all did talk about that, right? Lambert-Eaton syndrome?
Yes.
Yes. Okay. It's all a blur. I don't know when we learned anything. It's just bad. So I just want to make sure. Lambert-Eaton syndrome means that you actually have autoantibodies, same principle, autoantibodies against the presynaptic calcium channels, right? But with these people, it's exactly opposite of myasthenia gravis. When you ask them to repeatedly move, they get stronger with repetition. And the idea is that every time they repeatedly move, they get increased calcium in transfer, okay? And when you more increased calcium means the easier it is for you to move your muscle. So I like to think of them as almost polar opposites, right? And the reason an acetylcholinesterase, I did this in FDM, inhibitor would work is because if acetylcholinesterase blocks the breakdown of acetylcholine, if you block that enzyme, you'll have more acetylcholine in the cleft, right? Yes, Lambert-Eaton syndrome is for calcium channels. Yes, whereas this is acetylcholine, right? Right. Well, it would be right. So this one would be sodium, but Lambert-Eaton, I guess I was getting ahead of myself, is going to be calcium channels for sure. Yeah. Yeah, and you can see that here, these nicotinic receptors. I don't want to confuse anybody, so I'll just say that again. These are going to be acetylcholine receptors. The sodium is going to control that, and it's going to be postganglionic, whereas Lambert-Eaton syndrome is preganglionic, and those are calcium channels. So with myasthenia gravis, they get weakness with repetition. With Lambert-Eaton syndrome, they get stronger with repetition because there's more calcium available for muscle contraction. All right. Try this one. I'm not sure if Lambert-Eaton is primarily in the lower extremities. I'm not sure. Is that true? I don't know.
Don't worry, guys. With the Lambert-Eaton, and they really focus in on myasthenia gravis, but they're not going to test you guys likely on Lambert-Eaton because that you're going to cover it way more in term 2. It's not as high.
All right,
yield.
good. So these are going to be presynaptic calcium concentrations, and y'all are right. This is Black Widow, or the Black Widow spider, I think it's called, the black spider. Don't laugh, Lindsey. Lindsey likes, that's her favorite Marvel character. It's the Black Widow, that chick. Yeah, letrodotoxin, that's what we're talking about here. This is venom of the Black Widow spider. Yeah, so these voltage gated calcium channels. And keep in mind, because we did talk about this, you get very much similar results, right? Whether it's Lambert-Eaton syndrome and presynaptic antibodies, or you have this toxin, this letrodotoxin. Same principle, you can't get calcium. If you can't move calcium across to the muscle, you're not going to be able to contract it. Cool. Oops. All right.
So I have a question. I don't know if you guys saw that question in the chat that Maria asked, but because these genetics concepts are ones that we've already learned, if they ask about them, do you think those count as like the cumulative portion of it, or is that considered this time just because we're learning it right now as well?
It's tough to say, but a lot of times they do that. Like they like to carry things over that are like, they'll carry over a concept that was covered before, and if it was covered again now, like they can count it towards that. Yeah, it's hard to say, but yeah, that does tend to be the case. Like, yeah, common themes carry out through, especially genetics.
Okay,
All
thank
right.
you.
Yeah, no worries. Okay, so yeah, so a lot is made out of this. It's not as complicated as people make. If you were lifting weights, if you're doing bicep curls and you had a lighter load, like a lighter weight, you would contract it faster, right? Versus a heavier load over here. So the shortest length is going to be curve 1. This is the lighter load. If you're lifting higher weights or heavier weights, your shortening velocity is going to go down, right? It's going to take more effort to pull it up. It's the whole concept here, the load that is on the muscle versus the shortening velocity. So don't get too mixed up on that. That's all they're really getting at. And then these are just some basic definitions. Preload is going to, and we're going to talk about this much more detail when we get to cardio. Preload is the load at which it is the initial weight that you're holding in your hand before you actually contract, okay? But they're just introducing you to these concepts here. Yeah, but yeah, this won't be so bad on the test. It'll be pretty straightforward. All right, try this one. All right. Yeah, so the A band, and yeah, that is, if I'm hoping to have a graph. Yeah, A band is going to be the length of the thick fiber, right? So it doesn't change. The only thing that's changing is the thin fibers that come over the thick fibers, right? Now, the H band's going to change, right? Because as these thin fibers come closer, this H band's going to get smaller. So, and then the M line is going to be towards the middle. And let's see, yeah, so I band is going to get smaller. The I band is basically the part that's only thin filaments, but I like to define it as the end of a thick filament to the end of the other thick filament. Either way, it's the same thing, but as this green overlaps over the pinkish area, this I band's going to get smaller, A band's going to stay the same. Just draw this out once or twice as it's relaxed and as it's contracted, and you could work these out. The Z lines are over here. They kind of hold it together. H band's in the middle. H line or band. Band is in the middle. What's the line? M line. Yeah, it's been a while, guys. But yeah, that's in the middle. For some reason, I remember them asking about these silly little proteins on the side too. Titan, there was another one, I forget. But know those. There was like a chart of those that, but no Titan.
Anything that can cause the
Nebulin,
pathology,
alpha
like the
actin.
dystrophin.
Yeah, all those. Know those. Yeah, for sure. I think it was specifically Titan they asked, but yeah, know those. All right, let's see. Try this one. All right, so straightforward. Remember, smooth muscle is very different from striated muscle. Striated muscle is your skeletal muscle and cardiac muscle. Smooth muscle needs to be able to be tonically contracted, right? Like your gut, right? It needs to be tonically contracted at times without getting tired. So it's basically like this clipping system, right? You have to, whereas the skeletal muscle kind of, the tropomyosin and the complex kind of comes and goes, right? This needs to be able to be tonically contracted, and then it needs to be tonically released. So it's like an action to contracted and an action to release. So it uses this calmodulin system, right? So the idea is this myosin light chain kinase is phosphorylated, and you get this tonic contraction. And then you can dephosphorylate it and then get relaxation. Yeah. So definitely keep that in mind. I thought I had a chart. There might be a chart in your book or in your notes that has like skeletal, cardiac, and smooth muscle, and just the differences, the different proteins, the different enzymes. Definitely know the differences there. I don't know that they would give y'all any sort of histology with that. I know the trick, if you're looking at striated muscle, the cardiac muscle has branch points, whereas skeletal muscle is straight across. So I can't remember when y'all did that, if y'all did that for this test or not, but that's a good way of doing it. All right. All right. So the point being, let's talk about it in reverse, right? So this action, well, in regard to skeletal muscle, this action potential, they can almost overlap in regards that it could be tonically contracted. What happens if your heart is tonically contracted, right? It's not pumping, is it? So you have to have a period, a refractory or an absolute refractory period between the beats, and that's built in to the cardiac pacemaker cells. Y'all will get into that much more. We'll get into that next review for cardio, which will be much more fun than this nonsense. Right, so you can actually lock up or tetanize this skeletal muscle. And but obviously your cardiac muscle, you need to have breaks in between. You need to be able to pump, fill up the chambers, relax, right? Pump back and forward. Don't judge me, Lindsey. I see you. All right, and I threw this in here, I think, inside joke. All right, yeah, you need to know these. Remember the power stroke versus, it's always tricky, I always get this backwards, but the point at which the myosin head releases is the point when ATP binds, right? So it releases, and then, yeah, and then you get, where's the power stroke? This is the power stroke, where the ADP, I might be saying this wrong, oh Lord. How does this work, Kishore? ATP binds and it releases, right? Am I wrong about
Right,
that?
ATP binds,
Okay,
and
yeah.
then it creates ADP and one inorganic phosphate, right?
Right here,
And in
yeah.
that process, you eject it. So rigor mortis is when you don't have ATP and the muscles are just locked up, and that's it. They can't continue to move along this kind of cross-bridging structure, and it ultimately ends up it's somewhat similar to kind of tetany, but like for
Right.
this one, when we were asked questions about it, it was very specific to at what stage, where does ATP bind, and how it would look for like rigor mortis.
Right, okay, so yeah, I said that right. So the ATP, when it binds, it's gonna release off of the muscle, right? This myosin that's gonna release, and then you get this, then this hydrolysis, and then it comes back when it binds as ADP, and then you get the power stroke. So just basically keep in mind that ATP releases it. As Kishore was saying, obviously rigor mortis, after you decease, you don't have ATP, so they get locked up because ATP is not there to bind. One day, very soon, you won't have to worry about any of this anymore. It'll be all clinical medicine, and your patients won't ask about ATP binding or this power stroke or anything. This was that table I was talking about. Just knowing the differences in the enzymes, how it breaks down, stuff like that will be good to know. All right, and Kishore gave it away, but rigor mortis in skeletal muscle, decrease in ATP, right? No energy being made. This was from some silly DLA they gave y'all. Just remember that creatine, for those that work out and use creatine, it is an energy form. It is actually has more energy per molecule than ATP. So it can be used. That's why bodybuilders tend to use it. It is broken down into creatinine in the kidneys, which is a measurement of renal function. But just keep in mind that there are some higher energy compounds, particularly phosphorocreatine, that can be used for the muscles. And that's all for me. Lindsey, you got some questions? Should we take a break first?
Yeah, we can take a break, and then
Let's
I have
take a
some
break.
cumulative questions for you guys.
How exciting. All right, let's take a 5-minute break, and then we'll come and do questions.
Brady and Lindsey, there was a question in the chat, and I want to make sure we I mean, at least
Okay.
gave our 2 cents on it. Some folks were doing questions from like SNL and a couple of other resources, and they were kind of shooketh about like the nature of the questions, and like, you know, if they some of them were getting it right, some of them had issues with it. So I personally told them that it wasn't as exactly representative of what we got tested on, but it was, SNL tends to be often the gold standard that a lot of students do like the day before the exam or something like that. But I honestly stick to SGU questions, and that's what I do, and then Gray's questions.
I may be a little biased, but I do the IEA questions. I usually don't even bother with SNL. But if you're looking for extra questions, SNL's good. But I very much like the IEA questions. The old IEA questions y'all will find. I find those very representative of the test. How do you feel, Lindsey? Do you do SNL?
I used to do SNL. They were really good in term 1, but I felt like as you get deeper, I strayed away from some of the student made ones. You always got to be careful if you're using student made questions. I mean, when we do this, we just like we have a goal in some of the questions, and it's not necessarily always to be representative of the exam. It's more like to hit on points we really think you need to focus on and to make certain points and make certain statements about things. But as far as representative the exams, I would caution against using student-made questions to actually prep for exam style questions. I would use it more as looking at the information and seeing what you could be tested on and different points that students felt were important for you.
Okay, so I got a couple of questions here. The IEA question. Yeah. So everything, all the questions I have are on my drive. As you get into cardio, they may not be some for MSK, but as you get into cardio and respiratory and renal, I'll put them up on my drive for you guys. But yeah, I do those. That's the last set of questions I do before the exam. I try to give myself like a minute per question and go through those. After I've done the Sakai, reviewed the ESOF, reviewed the IMCQs, done the grades, IEA is like the last set I'll do, right?
Can I ask you guys a question?
Yeah, of course.
Regarding, so I had the content clinic this morning, and the facilitator there, kind of just gave a little like warning of continuously doing Gray's questions, and that I know this happens to me where you start to memorize the question and then just immediately go to the answer. So they were, kind of saying like only do a couple passes and try to just get a variety of questions. And I was wondering what you guys think of that.
So I would argue that if you start memorizing the questions, it's not because you memorize the question, it's because you memorize the patient presentation.
Yeah, for sure.
That's what I would say. Now the wording of different questions, I mean, yeah, you can make a case for that, but honestly, if you start memorizing the patient presentation and you're like, okay, I know what this is, I would argue that you learned that point, and it's not the question, it's the actual presentation.
As long as you could answer why, why is this the answer, then you should be good to go.
And why other answers are incorrect too.
Yeah, exactly. But bottom line is the more questions, the better. If there are no IEA questions for MSK on my drive, then I don't have any. But I'm pretty sure they're coming forward in cardio, because for MSK, there's so many Gray's questions, it's not super important. But as you get to cardio and renal and respiratory, it's harder to find questions. So the IEA questions will definitely come in handy. So just maybe hold off if there's nothing. Actually, I'll just go check and see. How about that?
Thank you.
Yeah, no problem. And y'all do know, like, if you go look at the additional resources, review questions. Yeah, I got old IEA questions on there for MSK. Yeah, so go, I'll show y'all. If you go to my drive, and y'all should definitely take note of this because I put a bunch of good stuff on there. If y'all go to the Scrubs drive, I put them in there as y'all go. So April additional resources, MSK. This is all kind of fun stuff. I pull stuff from first aid for you that I found helpful when I was doing it, specifically, the different areas. Yeah, so opposed to flipping through first aid, these are just the specific pages I like to go back at. There is the errata for Gray's too. Y'all might want to take a note of that. But the review questions are here, old IEA questions. Yeah, so go look at those for sure. And then as you go forward, yeah, that's going to be a good thing to look at. But yeah, all the honor students tend to write questions. They do it through the content clinic. Now IEA used to do it on their own. That's a whole long story. But yeah, so but all of the IEA questions that you'll find are older questions that the honor students put together. So yeah, IEA is the Honor Society. I'm the active president right now. So if you have any questions, you could reach out to me. As I said earlier, if you get above a 90 in term 1 or cumulatively going forward, you can join IEA, and we do all kind of stuff, including tutoring and all.
That's right. We have 2 El Presidentes.
Yeah. So the if you 90 or above, right? So 90 or above in term 1, and then cumulatively then on out, it has to be above a 90, right? The link to the page with the docs, if you go to the Scrubs page on Facebook, the About section, there's a link to the Google Drive. Just go there and find your term, and it's all there. Here, I'll just put it in the, yeah, but I do that for each of your, each module. So all my old stuff, whoops, all my old stuff is up there.
I really like Brady's summary documents too. He has summary documents for basically everything.
Oh, I do that too, right? So if you look, well,
I know
she
your
just
notes
got
better than
carried
you know
away.
your notes, Brady.
Like, oh yeah, I do that too.
Well, I might as well show you guys. So what I do before the exam, like, so let's say the exam is, what y'all are doing is like 3 weeks. So like 3 or 4 days before the exam, I will take a week at a time. Like as I go through and I listen to lectures during the the regular week, I'll highlight stuff and color code stuff. But the few days before the exam, excuse me, I'll make abbreviated notes. So if you go to the notes section, these are my notes. These are like down and dirty, like what I think is super important, things I wanted to like burn into my brain right before the exam. So all of your exams that you're going to have so far, I've posted all of these when you get next term as well. These are just kind of things that were really tricky that I wanted to make sure I remembered. So if you want to go look at those, you can. There's the anatomy versus non-anatomy stuff, but some people print these out and like to add stuff to them and whatnot, but it's there for you guys. Whatever you like to do, go for it. Yeah, do it today.
My MSK notes are up. Those are helpful. My ER documents is what Brady's referring to. Those has like all the embryological origins of all of the reproductive structures.
Yes, they're very well done. So Kishore will be glad to share his cute drawings with you.
When you guys get to CPR, I'll post the CPR notes as well.
When you're grown ups, you get to look at that. All right, can we start? Lindsey, you ready?
Yep.
I'm losing my buzz.
Oh my God. Okay. Where's my, here we go.
Oh, and just before she starts, I will add, so Lindsey doesn't post these questions. She wants y'all to do them without cheating. And after I will compile these with mine. And so the same link I'll use to get the previous, it'll have these as well. Emergency medicine, if you're curious, is fairly competitive. Yeah, it's good. 220-ish. Well, we're all going to be doing pass-fail step. But yeah, it's fairly competitive, emergency medicine. I put it in the middle range, maybe a little higher than middle. All right, all you, Lindsey.
Okay. So you guys know the drill, private message, either Brady or myself. These are cumulative questions. So you do have stuff from today and you have stuff from our last review. So. So there's kind of a mix here, which is fine. We'll explain it. So the positive Trendelenburg when she's standing on her right leg. So I'm going to give you about 5 more seconds. 4, 3, 2, 1. Actually, the right superior gluteal that is compromised in this patient. Do I have an explanation slide? No, I don't have an explanation slide. Does somebody want to explain why it's right superior gluteal?
I can.
Yeah, go for it.
So when you're standing on your right side, your gluteus medius and minimus will contract and it'll keep it on your left side like stable. But if it's not contracting and that nerve is compromised, then your the opposite side will like droop down, your like that pelvic area will droop down to the towards the floor.
Right. Yeah, and it is a tricky way of putting it, and I did it on purpose because you want to make sure that you are reading all of these questions very carefully, because the way they phrase it can kind of trip you up. So make sure you do understand this concept. If they put it on the exam and they do put it in a tricky way, that you know it well enough that you won't fall for it. So. So I have a couple trickier brachial plexus questions in here just because I want you guys to make sure you know everything that's coming off and at what point of the brachial plexus, and you can kind of draw it in your head. You have a visual of it. We're kind of all over the place right now. I'm going to go ahead and advance. So it's actually a trunk. So what nerve are we talking about here if he cannot initiate abduction?
Is it the supraspinatus?
Yes. So 0 to about 15 degrees is supraspinatus. And so if you notice, this comes off the trunk. So you need to understand the, real Texan street cold beer, roots, trunks, divisions, something, whatever. But you need to know them, and you need to know the major nerves that come off of the points. So you can be tested on that. Cord and branches. Thank you, Kishore. Yeah, you guys are getting this one. This is one they're going to test a few times on the exam, so make sure that you do understand this concept very well. I'm going to give a few more seconds to let everybody answer in. Okay. So this is L4. So herniated disc between L3 and L4. The L4 is going to be impinged coming out of that space. Gunner. Yeah, you guys are getting this one. So we're opening the presynaptic calcium channels and you get excess synaptic acetylcholine. For your purposes in term 1, just make sure you understand what's going on with these things. You'll learn more in like term 2 and beyond. But right now, just understand what the substance is and what it does. That's basically what you need for term 1. And that's your explanation slide, which has gotten blurry. Sorry, I apologize. This concept is very high yield. There's only a couple slides in your lecture notes on it, I believe. Please, please, please know all cutaneous innervation for every part of the body. Please know cutaneous innervation. There are enough that it could tank you if you don't understand. There's kind of a spread here, which is fine. That means we get to talk about it. I'll give you a few more seconds for those who want to click in or answer in. We're not clicking. Okay, so the answer, ilioinguinal. So the big thing here is it involves the medial thigh and pubic region. That's the big identifier here. If we're talking about upper medial thigh, that we're going for ilioinguinal. So, okay, I don't have an explanation slide here, but please, 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 like I said, know the cutaneous innervation of all of these. A, B, and C can get a little bit confusing because they have different branches and like, you know, they'll be motor versus sensory. Obturator, what is that? I can look it up. Oh, it opened up on almost the exact slide I wanted. I'm gonna get this for you. I'm just wanted to pull up the slide to show you.
I believe obturator does a lot of the medial thigh as well, especially the muscles of the medial thigh.
Yeah, but this is also including the pubic region. So it's the combination of the two that tells you what you're looking for right here. This is what I want. I'm gonna bring up the slide so we can all look at that together. If I can find it. Well, I can't find it. Let's circle that slide. Okay, I'm gonna try to find it and while you guys answer the next question. Okay, there are a couple different answers. The answer is calcification of the bone matrix. So the explanation of that, come on. Okay, my computer is not wanting to work right. Thank you. Does someone want to give it a shot before I explain it? Why it's this?
I can try, I hope.
Yeah.
This is, well, from reading the presentation, it's rickets. And because there's vitamin D deficiency, there's a lack of intestinal absorption of calcium and phosphate, which leads to decreased calcification of the bone matrix.
Yeah. Yeah, so the big thing here, we have that vitamin D deficiency. So we have defective calcification of the bone. And the reason is because you don't have adequate calcium or phosphate delivery. And so you can't calcify that bone since you don't have that available to you. So does that make sense? You can answer in the chat. Cool. Awesome. Okay, next question.
Just to add to that previous question, another thing that they talk about with vitamin D deficiency is not only inability for calcification of the bone, but you can actually get demineralization of the bone, minerals being the calcium phosphate, right? So you keep that in mind, that demineralization can be a sign of some sort of vitamin deficiency or vitamin D deficiency as well.
Okay, I found the slide I wanted. So after we talk about this, I'll go back.
That's a good question, Maria. I would assume so. Yeah, I mean, there's a lot of immunoglobulins and vitamins that are transferred in breast milk, particularly in the first couple of days. So yeah, I would imagine so.
What type of burn do we have here if there's charring in the area?
Second degree burn.
We're gonna have a third degree burn. So second degree burn, you're gonna see blisters in the area. And it's gonna be really red, but charring is when you have third degree and it's actual destruction of the tissue right there. So you should know the classification. What depth are you looking for with a third degree burn? How deep does it go? To what layer?
Subcutaneous.
Subcutaneous. And in this picture right here, what is going to tell you you're in the subcutaneous area? What are you looking for?
Fat.
Yeah. So the answer is going to be D, because you're looking for this area right here with the fat deposit. So subcutaneous. Okay. I clicked my space bar and okay, here we go. I'm going to no, my one note.
I have an answer, Maria. All vitamins except so you don't get adequate vitamin D, which is ironic because it's milk, but vitamin D and iron, everything else that comes through the breast milk. So there you go. Yes, type 2 burns, think of the 2 layers, epidermis and dermis, right? Blistering as well, right?
So back to our question about the cutaneous innervation. Somebody mentioned obturator. So obturator is skin on the medial thigh, but like I said, I included the pubic area, and so medial thigh plus pubic area, that was your identifier there. And iliohypogastric, just the suprapubic gluteal region. So it's that's a big one. It's that suprapubic region. Ilioinguinal, that's one we were talking about. And then genitofemoral, yes, you do have that those 2 branches. So you need to understand the difference between the branches. So skin of the femoral triangle versus the cremaster reflex. Then lateral femoral, anterior and lateral thigh. So I drew a little person right here and color coded it. So that's how I remembered it. That's how I studied it. So make sure that you are able to understand this entire dispersion.
Sorry, I just wanted to chime in too. Also for the clinical correlate for the appendectomy, that it's like specifically mentioned that the ilioinguinal ligament is something that you have to watch out for during an appy. So that was how I ruled out the other ones.
Awesome. Okay, let's go back to the questions. No, not that one. Okay. I forgot to change this to ABCD, so just you can put ABCD. Yeah, you guys are getting this. This should be one of those buzzword ones. So as soon as you see a child, any kind of swinging or something, you should be thinking about a nursemaid's elbow, which is the annular ligament. Another common way to get this is if a child is trying to run into a street and the parent pulls them back. That's another really common presentation that you can see. But any sort of swinging, any pulling motion, even just lifting a kid up from the ground by their arms can cause this dislocation. So this is hopefully a couple easy points on your exam. So this is just a slide showing that. Yeah, you guys are all getting this. They love malignant hyperthermia. So it is the ryanodine receptor right here. Yeah, so what's the nerve we're talking about here? I think everyone pretty much knows the nerve. What is that called? Yeah, musculocutaneous. So We are talking about the lateral cord of the brachial plexus. So the description, the lateral area of the forearm, musculocutaneous nerve, and yes, you do need to know. I made this a little tricky for you. They're probably not going to make it that tricky, but again, I wanted to kind of highlight the fact that you do want to go through the brachial plexus and know it inside and out, and know the different levels, terminologies, what comes off the different points. Yeah, this is the forearm because we're losing loss of sensation to the lateral forearm. So the forearm is the distal part. So musculocutaneous, lateral antebrachial cutaneous, off of the musculocutaneous nerve right here. Okay, so we are at the mid shaft here. What nerve? I had a couple people say it, but what nerve are we dealing with here? Yeah, we're dealing with radial, and a big thing is the wrist drop with the radial nerve. That's a huge identifier that you're dealing with the radial nerve. And then you need to know what nerves you're dealing with when you are talking about each of these positions. Yeah, you guys are getting this. What is this condition called first? It's bullous pemphigoid. And the way I remember this is that bulls are stubborn and they're hard-headed. And so these blisters are hard to break when you touch them. Or bullous below hemidesmus. And then the pemphigoid vulgaris are the ones that you can break very easily. And Brady had a question about that during the review part, but it's a hemidesmosome. So hemidesmosomes are at the basement membrane. That's where that's their attachment. And so the reason why they are so taut is because the desmosomes that are the lateral specializations, those are intact. And so you're not going to be able to break them as easily because laterally speaking, horizontally speaking, it's stable. But since you have those hemidesmosomes, it's forming like a fluid-filled blister underneath. Bullous below. And so that's why these are harder to break open than are the pemphigoid vulgaris, which are going to be the desmosomes. Did you have something to include, Brady? You're muted.
I usually draw the thing out. Can I annotate?
Yeah.
Oh, right. So like if you looked at these, just because Kishore did mention that they could show you a picture, right? these are the two different bulli that form. So if the problem is down here in the hemidesmosome below, bullous pemphigoid, they're going to be more up and down. They're going to be taut. And like Lindsey was saying, this lateral aspect, the demizones are intact. So you're not going to rupture it. Whereas here, they're going to be flat and the sides are going to be weak, right? So this is pemphigus vulgaris. And here, these desmosomes are weak, so it's easily ruptured. Okay, so if you keep that in mind, that'll make it easier for you.
Okay, there's a spread between two different answers. What are the different areas? Name the different areas. You can do it to everyone. You don't have to do it privately. I don't know if you can hear my dogs. There's a yard cur outside the window and they're going crazy.
So reserve, hyperprolif, hypertroph, calcified, and resorb.
Mm-hmm. So right here, we're looking at zone 2. So this is proliferation. So if we're producing new cartilage matrix, this is where we are going to see it, because you can see that there is this elongation and you are getting that proliferation there. Okay, we're getting a mix. That's good. Give you a few more seconds for those that still want to submit. Okay. We are talking about the common fibular nerve. Yeah, so who wants to explain why it's common fibular versus like deep fib or superficial fib?
You have weakened dorsiflexion, which is done by the anterior compartment. And then the lateral compartment does eversion, which is superficial nerve. So both deep fibular and superficial is affected, which is a branch of the common fibular nerve.
Exactly. So the common fibular is going to be more proximal. And if you get a lesion there, then everything that branches off of it distally is going to be affected. So make sure that you're reading these questions, because you've started to associate different actions with certain nerves. So make sure you don't stop at one. You need to read the whole thing, because in this example, you have two different actions applied by two different nerves coming off of the same one. So make sure that you are definitely reading all of this.
But I thought the deep fibular also has the fibula tertius, so, and it does eversion. And it says weakened versus destroyed. So then I thought the lateral was still available. The lateral
So
compartment.
weakened can also be a sign of nerve injury. I mean, weakness versus numbness, it's still the same thing, because you can get a paresis, which is weakness because of the lesion, a lesion or a damage or compression or something like that. So it's anything below normal right there.
Oh, okay.
I s-
And what
I-
did the LLE stand for?
Left lower extremity.
Oh, okay.
I see what you're saying, and you could argue that, but remember, like, one of the tricky things about this test is you have to pick the most correct answer.
Yeah.
So if they involve eversion, that common fibular, where the common fibula wraps around the knee, right around the head of the fibula. So it's commonly injured right there towards the outer aspect of the knee. So you couldn't be wrong if you went with the common fibula there. It'd probably be the most correct.
Okay, thanks.
So then had it said if eversion was still possible, but dorsiflexion was lost, then it's deep fibular.
Mhm.
Okay.
Yeah. Yeah, that's why I stress that you need to read the whole question and make sure that you can put these disabilities together to see if it's, you know, one thing or the other. I took this straight out of pre-test because I really liked this question. Okay, there's kind of a spread here. Okay, so the answer is A. So it's actin to the beta dystroglycan. So make sure you do know the structure of the sarcolemma and all the proteins associated with it, because it's very important to know which matches up where. Yeah, you guys are getting this one. You'll probably get a few questions on this. So make sure that it's hopefully a simple concept. So if you get it, you get it. And you'll get a few points. So we are talking about what's this rash? It's shingles from the herpes zoster, and herpes zoster lives in the dorsal root ganglion. And then if it gets activated, then you're going to have this characteristic vesicular rash in the distribution of that area. So it's around the umbilicus, so you know it's T10, so dorsal root ganglion. Please, 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 pretty please know the dermatomes, myotomes, all of that stuff. And not just it's not really a good way to study this, but if you know the common ones, then if they give you a weird one, you can find it based off of your knowledge of the common ones. So please know all of those things. Like I'm pretty sure we had one on one of the fingers and like it threw me for a loop. And I think the only reason I got that question right was because I knew other ones around it and I could reason my way to the right answer. So make sure you do know these. You will have maybe one or two questions over this kind of terminology. Yeah, most of you guys are getting this. So the cellulitis, the suffix itis just means inflammation. That's what that means. So suffixes and prefixes, I wouldn't memorize that entire list. But there will be like maybe 2 or 3 questions on it. Past scribes, that'll be easy for you. But it's not too difficult. Just scan that list. But if it's down to the wire, that is not the thing I would study at all. Yeah, you guys are getting this too. Make sure you know these injuries. Make sure you know the different ligaments on the vertebrae. Make sure you know the blood supply to the vertebrae. So all of you are getting this. This is anterior longitudinal ligament.
Bonus points if you know what this is called.
Yeah, Saturday night palsy. So what nerve are we talking about? I mean, it kind of gives it away, but what nerve is associated with Saturday night palsy? Think higher up. Yeah, axillary. Friday night, Saturday night. Could be both. Could be both. Friday or Saturday night palsy. Okay, so the answer here, we're getting wrist drop. Because you will, yeah, I just wanted you guys to go up a little further. Oh yeah, it is. Never mind. It is radial. Sorry, I tried to confuse you guys. But yeah, you're getting wrist drop. Yeah, Nicole, you're right. Okay, we're getting a couple different answers here. You should be focusing on pre-granulation tissue. That's the big identifier here. I'll give you a few more seconds. Okay, answer is migratory phase. So, oh, I don't have an explanation slide here, but pink granulation tissue is characteristic of this migratory phase. Please know all of these, you'll get 1 or 2 questions, but each of these stages has 1 or 2 things that is going to be indicative of that stage. So please understand the big points in all of those. Can y'all hear that? The dog's going crazy in the background. Yeah, you guys are all getting this right. It's depletion of ATP because as we were talking about earlier, you do need ATP to reset the system after you contract. And so if you can't reset the system, once ATP is depleted, then you won't release from that contraction and you have rigor mortis. I put this in here because everybody gets this. Why is C wrong? Hold on, I'm gonna look at that. Because it's the actual ATP depletion that causes rigor mortis. So SGU exams are single best answer. So the cause of rigor mortis is the depletion of ATP. Bilateral lower extremity, BLE. Okay, yeah, you guys are getting this right. Nucleus pulposus. Please know the difference between nucleus pulposus and the annulus fibrosus. People get mixed up on that all the time. It's the actual nucleus pulposus that is herniating through the annulus fibrosus and causing that bulge. So that's an important concept. It's a simple one. It's maybe 1 or 2 questions on the exam, but don't lose those points. These abbreviations are second nature to me now. I can't not do them. This is another pretest one that I thought was really good. If y'all don't know what pretest is, it's a question book.
And historically, of all the question books, pretest tends to be the hardest, just so you know, like compared to Guyton and Hall and BRS.
Yeah.
Like if you were to do those pretests, you do those closer to the exam because they tend to be harder.
I picked out ones that I felt were pretty good with the material that we have. If you have those question books, they're really good resources. However, you would need to go and pick out the questions that are applicable to the exam because they don't they go by system, but it's all encompassing, like, you know, because in year 1 you learn more anatomy, physiology, embryology. In year 2 you learn more the farm and the path and all that stuff. And so if you do use these question books, just be cognizant that going through these, you need to make sure that you are answering questions that are representative of that exam for you. But we have a couple different answers for this one. So the answer is it spreads inward to all parts via the T tubules. So please make sure you know the difference between skeletal, smooth, and cardiac muscle. There, I think I put a little, oh, I didn't, Lindsey, a chart in your notes that describes the structure, physiology, and everything for the different types of muscle. Please know the difference between those because they love to test you on the difference between them. So it's a very high yield point. If you guys don't understand the concepts of preload, afterload stuff in MSK, you're gonna learn it in CPR to a much more extent. This is just kind of the introduction to afterload and preload. So this is actually just a definition from your notes, and it's something that you don't notice in your notes until you get a question in an IMCQ or ESOFT, and you realize that you need to know it. I don't do math either. But this showed up in an ESOFT quiz, I believe, for us. And it really is just a definition from your notes. I'm getting a couple different answers. It's actually 1 gram. And I do have a slide on this. I remembered that. So basically the definition is that at 1 gram of preload, the muscle is at optimum length. Why is it optimum length? Because you have to have overlapping of the actin and myosin to even be able to contract. And so this 1 gram of preload just means that there is an optimum ability to be able to contract. So preload, it's like a spring. When you load it down, it's whatever you're loading onto it. And then afterload is going to be what the system has to work against. Again, that'll make a lot more sense when you go into the cardio stuff. This is just an introduction to muscle physiology and these terms. But for your purposes right now, just understand that this is a definition that you should probably be cognizant of on your exam. Okay, we're pretty much all agreeing on the same one, which is good. I'll give you a few more seconds. Okay, so the answer is Vmax, and most of you got this. So this is just knowing the graph. I'm sorry, this is a little blurry, but just know the different points. So you have Vmax, then you have Fmax. I don't remember what Fmax is, but just make sure that you understand these points and you understand the significance of them because they will test that. Yeah. So just to let you know, this is 1 pop, just 1 pop. So where is the needle? This has big clinical application right here. Give a few more seconds for those that want to. Yeah. So the answer, most of you got this, is the epidural space. So after that one pop, you do have you are in the epidural space. So I had one person do it. So what tissue are you actually going through to hear that pop? I have it. It's the ligamentum flavum. So make sure you do know this. What is the big clinical correlate here? Well, if you want a lumbar puncture versus a like an epidural, you want to make sure that you're in the correct space, right? Because if you want to give an anesthetic, you want to be more in the epidural space. But if you want to collect CSF for culture or to study, you want to go to the subarachnoid space, because that's where you're going to find that CSF. And so that's why this 1 pop 2 pop thing is extremely important clinically, because you want to know what space you are in so that you can either administer something or you can collect CSF. So make sure you do know the levels, the layers here. Of course, the big ones are going to be ligamentum flavum, epidural space, dura mater, and then arachnoid, subarachnoid space. Yeah, all of you guys are getting this. Anytime you're talking about changing the ion concentration, you are always talking about inotropism. You'll learn about metabotropism in term 3, term 4, something, I don't know. But anytime you're talking about ions, it's inotropism. Yeah, most of you guys are getting this. Yeah, we're talking about lateral specializations. We are talking about gap junctions. Gap junctions allow communication between cells. And so you can have the calcium spreading from cell to cell to cell, which is very, very important, because you want there to be a coordinated contraction of the heart. You don't want multiple places contracting at the same time. But this is the chart that I was referencing earlier in the questions, but make sure that you do understand the differences between the types of muscle. So this is what I was referencing last time, knowing the different spaces and what goes through those spaces, because if you have a penetration injury in one of those spaces, you are going to affect that particular area, and you need to know based off of the clinical presentation what you're talking about. But we are talking here about the quadrangular space. So what is located in the quadrangular space to lead to this clinical presentation?
Axillary nerve and post-circumferential artery.
Yep. So make sure you know all of these, all of the spaces. So triangular, quadrangular, triangular interval. Yeah, there's kind of a split right now, but the answer is it is a beta blocker preventing calcium channel phosphorylation. So this is the slide in your notes. And then that is all I have for you today. These will be added to the same presentation that Brady already posted with the answers there.
And I will I will post the recording as soon as it processes. Good luck. We'll see y'all in a couple weeks for cardio. It's much better, I promise. I like doing that. Cardio's fun. So
Thank you
Yep.
very much.
no worries. Let us
So
know
I
if y'all
had,
need anything.
I had a request to explain the difference between a beta antagonist versus a blocker. The blocker is essentially blocking the effects of whatever it's going on. An antagonist is, it's going to do the same thing, but single best answer, it's the beta blocker, so you're not getting the phosphorylation of those channels.
Thank you.
Yeah.
You guys got this. MSK's
Alright.
fun. I promise you guys, you're gonna do great.
It's not fun. It's not
Every
Keisha.
time we do MSK, this document is not posted yet, but it will be.
Yeah. Go look at the additional resources stuff on the drive too. There's a bunch of good stuff. Yeah. The questions Lindsey just did, I'll post them in the same file as I had. So click the same link and they'll just be added. I just have to add them on there. Yeah, I'll have it up in a little bit.
But every time we do MSK, I'm reminded of lockdown in Grenada, and
We
the
were shipped home.
exodus.
Yeah, we were
I
shipped
call
home.
it I call it the exodus because
The
it was
exodus.
literally like thousands of students being shipped off the island. I stayed. I did lockdown in Grenada. That was interesting.
All right, I'm gonna stop the
I have a quick
recording.
question.
Oh, go ahead.
There was from the first week, there was one DLA regarding the bones of like I think the humerus and all the upper limbs and lower limbs bone, and it has like billion bone markings. Are viewers
No,
for that?
No.
no,
Nope.
don't.
At DLA, I don't know her. And that sounds terrible, but trust me, like you don't need that one for sure.
Origin,
I-
insertion, the bone markings. No, I remember
you're
having to
good.
do that in podiatry school. Like I literally had to know every single bone marking, every single groove, every single like everything on these bones. And they would just put one in front of you and you would have to be able to tell if it was left versus right. And then you had to know all of the origin insertions based off the bone markings. I'm so glad we don't have to do that here because that was a pain. It was a pain.
What about like the muscles and the bones like on an imaging? Would it be more of like a clinical question, like what kind of fracture is this? Or would it be like point to the ACEs on the CT?
No,
It'll be clinical. If
no,
they
it's clinical.
if they give you some sort of X-ray or imaging, it'll be straightforward. It'll be like fracture of the scaphoid. They'll be like somebody fell in the outstretched hand, and then they'll show you the image. I mean,
Okay.
it'll be straightforward. Yeah.
Okay, thank you.
Mm-hmm. All right, I'm gonna stop the recording. Again, good luck, guys. Just message us if y'all have any questions. Y'all will do fine. Trust yourself.
Yeah.